Hello, I'm Mimi Alliance, and I'm a student here at UCF College of Nursing. I'm enrolled in the F&P DNP program track. Today's video presentation consists of a SNAPS report that I am presenting to my preceptor today on patient with initials DS. She is an 84-year-old Caucasian female that has been enrolled in the hospice care program since March 5th, 2024. During the home visit consult, I was able to observe that the patient was confused and had incoherent speech. So most of the history of present illness information was conveyed by her granddaughter. The chief complaint is increased confusion and cold symptoms. Patient has a significant past medical history of COPD, hypertension, cerebral atherosclerosis, and severe dementia. The patient's granddaughter let me know that the patient has been experiencing increased shortness of breath, increased fatigue, worsening cough, increased sputum production, decreased appetite for about 3 days now. The patient's granddaughter described her mucus production as green. During physical examination, the patient was constantly coughing, and her sputum production on 2 occasions was green and yellow. Also, during physical examination, I was able to auscultate the lungs, and there were significant rhonchi in the left upper and lower lobes, audible rhonchi. The patient's vital signs: blood pressure was normal, 122/74. The temperature was 99 degrees Fahrenheit. Some significant findings with the vital signs: the oxygen was 85%, and the heart rate was 103, and respiration's 22. The patient has PRN oxygen prescribed, and I was able to go ahead and put that nasal cannula on her and bump her up to about 6 liters. Her prescribed dosage is 4 liters per minute. With the 6 liters, she was satting at about 98%. Based on these findings, I'm leaning towards a primary diagnosis of acute exacerbation of chronic bronchitis, ruling that in because the increased need of supplemental oxygen, the hypoxia, her persistent cough, and with all the shortness of breath and fatigue that's in the scattered rhonchi, that's why I'm considering that diagnosis. She didn't have a fever present, and her blood pressure wasn't high, but in the elderly population, when there's an infectious process going on, we don't always have a fever. Some other differential diagnosis would be COPD exacerbation and acute bacterial pneumonia. The COPD exacerbation, I'm considering that because of the persistent cough, but there really isn't any episodic dyspnea. And with the acute bacterial pneumonia, she does have decreased appetite, but I'm not seeing the hemostasis or fever that's usually present with bacterial pneumonia. So with the plan, I'd like to prescribe her the DuoNeb nebulizer Q6 PRN 90 mLs, and make sure that we educate the patient's family on the proper use of the nebulizer with the mask. We're going to prescribe the prednisone. Corticosteroids are very important to bring down that inflammation, so we'll prescribe 40 milligrams daily for a short course, about 5 days. Also, antibiotic Augmentin, we're going to prescribe that at the 500 milligrams over 125 milligrams for Q8 scheduled for 7 days. We need to educate the patient's family on proper oxygen safety in the home and the fall risk with the patient being fatigued. A question I'd have for my preceptor is, we know with hospice protocol, we're not going to order labs routinely. But with this patient situation, should we consider if there's a viral process going on versus a bacterial process? What are your thoughts on that? And thank you.